All right, so I'm not going to be able to see the chat. So if anyone, you're like, you'll have to yell at me, okay? If you have any questions or anything, feel free to interrupt at any time. All right, so today we are covering asthma and COPD. So first, let's talk a little bit about asthma. So both of these like overlap so much that I'm just gonna like kind of go back and forth and talk about them together. So asthma affects children and adults, and it's the most common chronic disease among children. According to the WHO, it affected 262 million people in 2019 and caused 455,000 deaths. Most of these deaths occurred in low and lower to middle income countries where it was underdiagnosed or undertreated. So what happens in asthma? So this is a reversible airway obstruction. It's due to inflammation and secretions in the bronchi. So if you can look at this like image over here, you get spasms of the muscles that are surrounding your small bronchi, and then you get all this like nasty secretions and inflammation. So you can see the diameter significantly decreased, which is why you can imagine people present with shortness of breath, cough, wheezing, and chest tightness. The symptoms are often worse at night or during exercise, and their acute exacerbations are often triggered by viral illnesses, dust, smoke, fumes, weather changes, grass, pollen, fur, feathers, soaps, and perfume. It's important to ask the patient what they think their trigger was when you see a patient with an asthma exacerbation so that they can hopefully prevent future exacerbations from occurring. It's also important to instruct people not to smoke around their loved ones that have asthma, because that definitely triggers it. And it's very relevant in children that their parents smoke around them. So COPD, it affects 5% of the population, so very common. Interestingly, I looked up the most common causes of death in both Vietnam and the United States. It's the 4th ranked cause of death. It occurs because of chronic inflammation of the small airways. So they get narrowed, as you can see here. And then you also get destruction and the overall reduction of the alveoli. So most of these people, of course, have a history of cigarette smoking or some environmental exposure or alpha-1 antitrypsin deficiency. Almost all of COPD exacerbations are triggered by infections, unlike asthma. 30% is attributable to environmental factors or an unknown etiology, and your most common organisms are listed here. So these patients present for both asthma and COPD. They present in it's a spectrum. So the most mild cases you can see are like this guy, they look fine. You wouldn't even know that they were sick unless you listened to their lungs and heard wheezing and you got a good history from them. So they might just complain of dyspnea, wheezing, cough, chest tightness. Then another next step up would be increased work of breathing, tachypnic, retractions, accessory muscle use, or tripoding. So you can see this woman here is tripoding, leaning forward. And this picture here, it's kind of blurry, but it's showing the accessory muscle use. The patient might be unable to speak in full sentences. So when you're obtaining your history, they might have like 2-word dyspnea, 3-word dyspnea. Hypoxia, agitation, or altered mental status, particularly when they become hypercarbic. So their CO2 level rises and they become altered. And the worst thing that I can think of with a patient with COPD or asthma is if they have no wheezing or if their chest is silent. And that means they are so bronchoconstricted, they are not moving any air into their lungs. To diagnose asthma or COPD, technically you need pulmonary function tests to do that. But obviously in the emergency department, we are not going to do that. So it is a clinical diagnosis for us. There is a large differential diagnosis for wheezing, as you can see written here. The one I would like to point out is heart failure. So we have to think of pulmonary edema as a cause of wheezing in these patients when they present. because anything that irritates the bronchioles or bronchi can cause wheezing. So fluid on the outside of the bronchioles can cause them to constrict and cause your patient to wheeze. An easy way to look for that is just to pick up the ultrasound probe and see if they have pulmonary edema by looking for B lines. This guy right here is a rapper from the United States. He calls himself Wheezy. So workup for these patients. So chest x-ray. Whenever you have a patient that has asthma, it is not routinely recommended to get a chest x-ray. It really only matters if you think they could have pneumonia, pneumothorax, heart failure, or something else going on. But in a patient with COPD, they are at increased risk of complications, so you should get a chest x-ray. This is slow. Okay, so what about blood work? Most patients do not require any blood work, but you should consider performing an ABG or a VBG if the patient is sick and you want to see their carbon dioxide level or their pH to see if they are, like, how severe their exacerbation is. Also, if you think that they could have cardiac pathology, you might want to add a troponin or a BNP. An ECG is not important for asthma usually, but it is important for patients with COPD because they commonly suffer from cardiovascular comorbidities. You'll often see AFib and aflutter or multifocal atrial tachycardia, and especially they can get this during their exacerbation. For treatment, we are going to do a lot of things. So we'll talk about oxygen, inhaled bronchodilators, Iprotropium, systemic steroids, adjuncts, and then our severe patients. So first, talking about oxygen. So for our asthmatic patients, these patients are not chronically hypoxic. So they are not used to being hypoxic. So we need to make them normal when they come in. So provide supplemental oxygen and keep their SATs 93 to 95%. And if they're pregnant or have other comorbidities, you should keep it above 95%. Contrast to that, our COPD patients, so we should correct their hypoxemia, but only up to 88% to 92%. The reason is that most people, like me or you, our respiratory drive is driven by our carbon dioxide level. And these patients with chronic obstructive pulmonary disease have chronically elevated carbon dioxide levels. So their respiratory drive is driven by their oxygen level. So if you make their oxygen level 97%, then they will stop breathing. And what that means is their carbon dioxide level that was already 65 is now going to be 95. And you are going to not only make them stop breathing, but you're going to make them extremely altered and they are going to decompensate. I think this is like a super important thing to teach nursing staff also, because often I see the nurses place the patient on oxygen and make them 100%, which is bad. So inhaled bronchodilators, this is absolutely crucial for the treatment of both of these patients. We're talking about albuterol, which is a short-acting beta-2 agonist, or also called a SABA. So beta-2 agonism, if we remember our receptors, this relaxes pulmonary smooth muscle. And so that causes bronchodilation. So if you remember that photo where all the muscles are constricting on the airway, we want to relax those muscles. So the side effect of albuterol is going to be tachycardia, tremors, headache, intracellular shift in potassium. So you can get hypokalemia. If you were at when I was there in person and taught back in, or I guess it was September, October, and I taught the lecture on hyperkalemia. So if you remember that albuterol is one of the treatments for hyperkalemia. So this makes sense. It causes hypokalemia. So the onset of action for albuterol is less than 5 minutes. And the good news is that in patients with asthma, almost like nearly 3/4 of them can, if they respond to like 3 doses in the ED, they get to go home. The dose is going to be 2.5 to 5 milligrams of inhaled albuterol per treatment. So you can tell your nurse or whoever will be administering this, give them 2.5 milligrams inhaled albuterol every 20 minutes. Or you could say do continuous for 1 hour and put 10 milligrams in the little breathing treatment. Our next thing is inhaled iprotropium. So this is a short-acting anticholinergic. The way this works is that it decreases cyclic GMP. So this is your little diagram over here. So you're basically by blocking cyclic GMP, you get bronchodilation. So your muscles cannot constrict. So this improves pulmonary function, reduces hospitalizations, and reduces the length of ED treatment when compared with only giving your patient albuterol. So you should be giving your patient albuterol and iprotropium. This is only beneficial though in the acute setting. So it's very important for us in the emergency department, but once your patient is admitted, it doesn't matter. The dose is 0.5 milligrams nebulized, or if they have an inhaler, it's 8 puffs. And you can repeat that up to 3 times. So you can take it's like liquid, just like the albuterol. You can take your iprotropium and dump it in with your albuterol and have them nebulize them together. Steroids. So steroids are super important as well. Systemic steroids are recommended for all like COPD and then all asthma, except for the very mildest cases of asthma. These are the main defense against relapses. They reduce airway inflammation, and so people get improved symptoms, speedier recoveries, decreased hospitalizations, and decreased length of stay. The effect begins within 1 to 2 hours and peaks at 4 hours. And multiple studies have shown that giving them early matters. So as soon as you see your patient, you should, give them the albuterol and the iprotropium, but also give them the steroid because it matters not to give it later. So do we want oral or IV? And there is oral administration preferred over IV administration. The reason is that oral steroids, hold on. Hey, quick. Sorry, my dog's going nuts. He has an ear infection. Okay, so oral steroids, they are less invasive, less expensive, and they're quicker to administer, and they achieve the same efficacy as IV steroids. The dose is 40 to 60 milligrams of prednisone. This is freezing. But obviously you can't always give someone oral medications, especially when they're in respiratory distress. So if they're not tolerating PO intake, then, or if they have significant increased work of breathing, if they are altered, then you want to give IV, of course. So the dose is methylprednisolone is 125 milligrams. So then whenever you discharge your patient, you should be sending them home on steroids to prevent relapse. So 5 to 7 day course, and there is no need to taper steroids. The optimal doses range widely. I couldn't find like a definite recommendation, but the overall recommendation is that you want an equivalent of 40 to 60 milligrams of prednisone for approximately 5 days. So this is an example, hydrocortisone 160 or Dex 6 milligrams. So next is IV magnesium. So this causes rapid, smooth muscle relaxation and bronchodilation. So relaxing those. It works as early as 2 minutes after infusion and lasts a couple hours. It should be given to patients who have life-threatening exacerbations. And if your patient remains very, very sick after an hour of therapy. It improves lung function in patients with severe asthma exacerbations and decreases hospital admissions. It is not beneficial in patients with mild exacerbations of asthma, and the benefit in COPD patients is unclear. That being said, if I have a sick COPD patient, I am still giving IV magnesium. A lot of these patients have simultaneous like asthma or similar pathology to an asthmatic, so it can still help them in some situations. So I still give it. The dose is 2 grams IV in adults, and the side effects of magnesium: hypotension, flushing, heart rate changes, and muscle weakness. So you might consider giving this with IV fluids if you're concerned that your patient will become hypotensive. Next, we'll talk about systemic beta agonists. So terbutaline is one of these. This is your patient that is so sick that you are worried that you are going to have to intubate or they're going to die. And so you are throwing, in English, we call it throwing the kitchen sink at them, which means you're trying everything. So terbutaline is a short-acting specific beta-2 agonist. So it specifically works on the beta-2 receptor. Unlike, we'll talk about next, is epinephrine. Epinephrine works on both beta-1 and beta-2 receptors. So terbutaline, you can give it IV, sub-Q, or technically nebulized, but I've never heard of that, and the data is not good for nebulized. So really IV or subcutaneous. So the data is not very good for this, but some studies have shown that it works particularly in children, but there's no convincing evidence for use in adults. It causes significant tachycardia because you're stimulating their beta receptors on their heart. And you're going to give it subcutaneously, 0.01 mg per kg, and then you can do it for up to 3 doses every 20 minutes. So when I've given this, I've given it probably twice in my career, and both of them, the patients were so sick, they were like gonna die, or I was gonna have to intubate them. And this medication, actually, after giving it, they turned right around, and it was the subcutaneous dose, 0.01 mg per kg. So the other option is epinephrine. Epinephrine has been used for a long time for asthma, and it is non-specific. So it hits your beta-1 and your beta-2 receptors. So again, you'll get bronchodilation, but it also causes vasoconstriction because it hits your beta-1 receptor. So you get decreased mucus production. So one study looked at, is epinephrine better or is terbutaline better? And the answer was that terbutaline actually worked better for bronchodilation. The problem with terbutaline is that you have to usually wait for that to come from the pharmacy because we don't use that often. Whereas epi, you can just grab an EpiPen, or it's in your crash medications in your emergency department and administer it. The dose is the same as anaphylaxis. And you can also give IV boluses. So next, we'll talk about Heliox. This is, again, your dying patient. So Heliox is a titratable mixture of helium and oxygen, and it promotes a less turbulent airflow through their narrowed airways. The reason this works is because helium, if you remember your periodic table, it has a lower molecular density than oxygen or nitrogen. And so your patient has a reduced work of breathing. And they get the drugs that you're utilizing easier, and it ultimately prevents respiratory failure in patients when you use it. The problem with Heliox is that if your patient is really hypoxic and they're requiring more than 30% of supplemental oxygen, then it doesn't work. So if your patient is really hypoxic, it won't work. The evidence is mostly anecdotal, but that being said, the guidelines do recommend considering Heliox-driven albuterol in patients with severe life-threatening exacerbations who are not responding to standard therapy. Invasive, this is, I think, is so important in these patients, and I've seen so many patients turn around because we use BiPAP. So this results in direct bronchodilation. So you get recruitment of the small airways, and it facilitates the administration of your inhaled beta agonists. You can get improved oxygenation, decreased work of breathing and fatigue, and prevent intubation. And I've seen so many patients not get intubated because of this. So it ultimately provides rest for the patient's diaphragm. The problem with it is that it does require a cooperation of breathing spontaneously. So you cannot have an altered patient because the patient has to be able to take the mask off their face. Or you don't want a patient that's been vomiting because they can aspirate. So the recommended starting regimen that I found was an inspiratory positive pressure of 8 and an expiratory positive pressure of 4. And then you can increase those pressures as needed. The studies show that BiPAP decreases admission rates, decreases ICU admissions, decreases duration of ICU stays, and causes overall shorter hospital stays. If you have a pediatric patient, which normally, we don't have, so I wasn't going to talk about it much, but they will freak out if you put a mask like that on their face. So you can try high flow nasal cannula. It doesn't work as well, but it is another option. So ketamine. Ketamine causes bronchodilation and bronchorrhea, which aids in the clearance of mucus plugs. This is the induction agent of choice when you want to intubate these patients because of the bronchodilation. And it also does not suppress their respiratory drive. It can, however, cause these side effects: tachycardia, hypertension, and theoretically increase intracranial and intraocular pressure. Antibiotics. So these are not recommended for the treatment of asthma, but they are in COPD. If a COPD patient has really minor symptoms, then you don't need to give antibiotics. But if they are elderly, have severe disease, comorbidities, or if they've had more than 2 exacerbations per year, then you should consider antibiotics. And there is no specific recommendation for which one to give, but these are several options that you can consider. Methylxanthines, which is like theophylline, these are not recommended because they have significant side effects and they have not been shown to work. So next, we talk about intubation. So the decision to intubate a patient with severe asthma and COPD should not be made lightly. It is a big deal. It can result in laryngospasm, worsened bronchospasm, hypotension, and worsened hyperinflation, and cause barotrauma and like a tension pneumothorax. You can also cause peri-intubation arrest. So patients who are mechanically ventilated have an increased mortality and longer ICU stays. That being said, if your patient is gonna die, and if you've tried everything else and they can't keep up with their work of breathing, then you should intubate them for sure. Or if you check a blood gas and their carbon dioxide is through the roof and they are not compensating, then you have to intubate them. So if we have to intubate these patients, then what do we want to do? So you can either choose like volume controlled ventilation or pressure controlled ventilation. And there's not like specific guidelines for which one's better. Usually you will choose whatever you're comfortable with and what your facility is used to using. There are like benefits of either one or negatives. So volume controlled ventilation. So there you're setting the volume. So a patient is going to get a certain volume, but that being said, you don't know that with that volume, you don't know how much pressure that is going to be delivering to the lungs. So that is why they can get hyperinflation and barotrauma. And they can also get breath stacking. So breath stacking is where the patient is not able to exhale all the way, and then you are giving them additional volume in their lung, and it's just their lung is hyperinflating, inflating until it can pop and cause a pneumothorax. Then there's pressure controlled mode. So pressure control, you're setting the pressure, which is great from a barotrauma standpoint. But that being said, you might set a pressure and then your patient is not getting any volume into their lung. So the problem is that they might not be ventilating. So your CO2 might increase. So the problem with these patients, like asthmatics and COPD patients, is that they can't exhale, which is why they get air trapping, which is also called auto PEEP, because they're so bronchoconstricted. So you can get air in, but you can't get air out. So that causes hyperinflation, possible barotrauma, and then hypotension. So what we want to do on the ventilator is to require or to allow them a longer time to exhale. To do that, you can decrease their respiratory rate and you can prolong their E time or their expiratory time so that they have time to exhale. So you want to start your settings low and slow. Your tidal volume should be set to 5 to 8 milliliters per kilogram of ideal body weight, and your respiratory rate needs to be low at 8 to 12 for adults, with goal plateau pressures low at 25 to 30. And the thing is that you're purposely hypoventilating them because they can air trap and they can hyperventilate themselves. So you want to hypoventilate them, which means that your patient might try to breathe over the vent, which is bad. So you might have to give them significant sedation and possibly paralyze them so that you are controlling their respirations and not the patient. You also want to make sure after you intubate them that you are constantly giving them albuterol. So you need to still give them albuterol even though they're intubated. And then, like I said before, the hypoventilation that you are requiring on the vent can cause the patient to become agitated. So you need to consider paralyzing them. Last ditch effort is going to be ECMO. And if they're not meeting the mechanical ventilation goals, then you should try ECMO. It allows the lungs to rest and allows bronchial relaxation and aggressive pulmonary hygiene. So disposition. Obviously, I think we know like when a patient needs to be admitted, that's really just like a clinical decision, admitted versus ICU. But it's really, I think the more challenging thing is like who can go home. So potential discharge if they have no or minimal wheezing, if they feel better, if they ambulate without hypoxia. And then I'm going to be honest, I don't ever check these peak expiratory flows and stuff. If you do, that's wonderful. I should, but I don't. But this is your recommendation if you do check those. You want to make sure that you're discharging them home with albuterol inhaler and with oral steroids for 5 days at least. And then if they have COPD, consider antibiotics like we talked about. And then this little tip down here is something that I also admittedly have not been doing. And so I need to start doing this. It's very helpful if you have a patient that has asthma, and you can look up the criteria of the different types of asthma. But if they have persistent asthma and they're not already on an inhaled steroid, you should start that because there are studies that have demonstrated a decrease in relapse in patients that are using inhaled steroids after discharge. That's a chronic medicine, and that's not something that we administer in the emergency department, but we can at least write the prescription for them. All right, so I'm going to go ahead and start the questions if that's okay. So someone has to shout out what you think. A 28-year-old woman with a history of asthma presents to the emergency department with difficulty breathing. On auscultation, you note diffused end expiratory wheezing. She's using accessory muscles to breathe. Her chest X-ray shows hyperinflated lungs with a narrowed mediastinum and no focal airspace opacities. She reports being 10 weeks pregnant based on her last menstrual period. Which of the following medications is contraindicated in this patient? I can't see the chat, so. Anybody want to shout it out? All right, the answer is epinephrine. So it's all of these other medications, albuterol, magnesium, and steroids, absolutely give that to your pregnant patient. The one thing you want to avoid is epinephrine, and that's because it causes vasoconstriction. And so your placenta is how the baby is living, and that is going to cause hypoperfusion to the baby. All right, next question. A 23-year-old man presents to the ED with a chief complaint of difficulty breathing. He has a history of asthma and is poorly compliant with his maintenance medications. Immediately upon arrival, an albuterol and iprotropium continuous nebulized breathing treatment is initiated by respiratory therapy. On evaluation, you find the patient to be somnolent with his eyes closed, but arousable with sternal rub. On lung exam, he has minimal air movement with faint, prolonged wheezing and clear evidence of subcostal retractions. Vital signs, pressure is normal, heart rate 110, respiratory rate 32, temp normal, O2 sat 90% on nebulized treatment. What is the most appropriate next step in the management of this patient? Somebody shout it out to me. All right, intubate them. So this person needs to be intubated because they're somnolent, and he is requiring sternal rub to wake him up. So like giving him mag is not going to help, or it's not going to save him anyways. Same thing with Terbutaline, same thing with Heliox, and then BiPAP. He cannot do BiPAP because he's altered. So again, no BiPAP in an altered patient. Next question. An 82-year-old man presents to the ED with a change in his breathing. The patient is nonverbal at baseline and has Alzheimer's dementia and chronic obstructive pulmonary disease. He uses 2 liters of oxygen via nasal cannula at baseline. His daughter feels his breathing is worse than usual. Temp 99, blood pressure 164/99, heart rate 92, respiratory rate 32, oxygen is 78% on 2 liters. Physical exam reveals a nonverbal, minimally responsive man who is acting at his baseline for his daughter. The patient is given albuterol, iprotropium, methylprednisolone, and azithromycin and started on BiPAP. A chest x-ray has no acute findings. He is observed in the ED. Subsequent oxygen saturation is 90%. An ABG reveals 7.24, PO2 77, PCO2 74. His respiratory rate is 27, but is breathing less deep than he was previously. What is the most appropriate next step in management? Yeah, intubate the patient. Yep, so intubate him because he is not compensated. So he is acidotic. There's a respiratory acidosis. So oftentimes when you get your gas, you will see a very elevated PCO2, but their pH might be normal because they're chronically hypercarbic, and so their bicarb is also elevated. But this guy is not compensating, and he's clearly crashing and burning, so intubate him. All right, this is just a reminder of the vent setting. So what's different about a vent setting in a patient intubated? A lower respiratory rate and a prolonged expiratory phase to avoid air sacking. And last question. So 60-year-old history of COPD comes to the ED for respiratory distress. He is in obvious distress, unable to talk with pursed lip breathing and subcostal retractions. Nasal cannula oxygen, nebulized albuterol, and magnesium failed to improve his condition. Which of the following, if present, would be an indication for intubation and mechanical ventilation? A, altered mental status, because he's compensating here. His pH is normal despite hypercarbia. And then here, that's fine. That's his goal sat with COPD. And then that is concerning, but definitely not relevant here. And that's the end. Any like thoughts or anything? Yeah. Well, yeah, but the thing is though, like he might live with a CO2 that high. He might live with a CO2 of 60 if he's awake, and then you could try. I think like if you just have a hypercarbic patient that's awake and not altered, then you could put them on BiPAP.
Not really. Okay, the same as steroid. Okay.
Yeah, you all have to start using it. It's amazing. It's so helpful in hypercapnic patients. It's life changing. It is, I promise. Like if I have a sick COPD, sick asthmatic, whatever, then I mean, I'm like, I tell the nurse, like, start albuterol, iprotropium, 2 grams IV magnesium, 125 milligrams IV solumedrol, which is methylprednisolone, and put them on BiPAP. And then I come back 5 minutes later and they look like a new person. And it avoids intubation. It's great. Yeah. Do you have respiratory therapists that come or not? Yeah, that would be really helpful because it's just so much work that's taken away from you. And then they can, like, their job is to pay attention to that because you have better things to do. Yeah. 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 Ask Dr. Tao to hire respiratory therapists. Right. Yeah. So maybe in the next 5 years, 10 years. Yeah. Yeah, maybe. All right. Anything else? Yeah. Yeah. Yep. Thank you all. Have a good day. Matt says what? Uh, oh yeah. So like okay. Okay, awesome. Yeah, I actually I might come back in April if that's okay. Yeah, thanks. I know. Yeah, it's so pretty. Um, yeah, and I think if I come back in April, we should go into the sim lab. I should do sim lab. Sounds good. All right, have a good day at work. Bye.